from the very beginning and about the reproductive system. All right. So here we have this is an embryo. It's about 12 weeks of gestation, and the question is at what time the gender is going to be established in this moment. Actually, the gender, as you can tell, is going to be determined at the time of the fertilization. Then after that, all embryos are going to be males and females. Okay, so what does it mean? Is that the external genitalia is going to be similar until certain moment. The genetic gender is established at the moment of fertilization, boy or girl. But then it's going to start having some differences of the hormones that are going to happen, especially about 7 weeks of gestation. 7 weeks of gestation, some organs, so the part of female and male, in case of male, the male are going to start to is going to persist. Meantime, the female portion are going to start to degenerate because of this genetic information that is going to make elevation of certain hormones, as we are going to see now. All right, so today is about talking about the testicles. And the testicles, we already know by previous anatomy courses that is going to be established in the scrotum. The scrotum is a sac, it's a muscular serous membrane sac that is going to keep the testicles outside of the body in order to decrease the temperature, in order to preserve the spermatogenesis. But the testicles, these organs, are not going to be from the very beginning in the scrotum. They are going to start migrating from the retroperitoneal area at the level of the kidneys. So we will see the migration in a few moments, and this is going to have some anatomical element that we're going to talk about the testicles. Cellular differentiations, we have 7 weeks, is going to start having this difference on what? On hormones. The hormones are going to play a role important in order to determine the external appearance of the organs. Okay, so we have hormone production. It's going to be about 7 to 8 weeks. And we have the interstitial cell or Leydig cells. These are going to produce testosterone. And the Leydig cells are one of the two cells, the Sertoli and the Leydig, that we are going to see in the next slides. And the Leydig is the one who produces testosterone. So a way to remember this is just a way to remember ladies like testosterone. So lady produce testosterone, and at the same time, these Leydig cells are going to produce the anti-Mullerian hormone. So if you see here in this chart, in this graphic, we have here the Mullerian duct and the Wolffian duct. The Mullerian duct is going to be for the female reproductive system, and the Wolffian duct is going to be for male. So at the beginning, that's what I was saying, that at the beginning everybody is female and male, because everybody is going to have these two structures. Then at 7 weeks, the Leydig cells are going to start producing what we call the anti-Mullerian hormone, that is going to make degeneration of the female reproductive part. So it's going to stay only just the male. Okay? All right, so the genital characteristics, the earliest that you can find out the gender of the fetus, first of all, appearance is going to be the same, 7 weeks, 8 weeks, 9 weeks. So an ultrasound, that is the tool that we have, they are not going to be able to differentiate the external organs. So when is going to be that? About 12 weeks. At 14 weeks, they must be seen already. But at 12 weeks, you start to see the external genitalia differences between male and female. So that is the earliest that we can observe the external genitalia. So here we have, remember we was talking about the testicles that are being located in the retroperitoneal, so very high at the level of T12, L1 in the retroperitoneal area. The testicles are start to descend, and they are going to go through, so they come from inside the body, outside the body, and that is going to be through the inguinal canal. The inguinal canal is like we put, it's a canal that is formed the walls by the muscles and membranes that is going to make the, is going to transport the testicles from the retroperitoneal to the scrotum. Okay, so if we see here, here's the abdominal wall, this is the pelvis, you can see here, and here we have layers of muscles, and here we have some serous membranes here, and this is going to be like a cavity. If you see here, that is the exit of the inguinal canal. If you put your hands in your pockets, like in your pants, that is about the direction of the inguinal canal through the lower portion of the abdomen. Now, this canal is, we are going to see it, is like a tunnel, like a channel. It's a virtual channel. So it's like a tunnel. Inside this tunnel is going to pass the testicle. And the testicle is going to be part of what we call the spermatic cord. The spermatic cord. What is the spermatic cord? Spermatic cord is the testicle, are the VAN, means vein, artery, and nerve, lymphatics. They are going to pass from, can you see this pathway? From the abdomen, they're going to descend all the way to the scrotum through this detail here. If you see here, they're going to pass the abdominal wall, the spermatic cord with all these surrounded by some muscle there too. They're going to be surrounded, the arteries, veins, and lymphatics with the testicle. So that is a pathway. So they are going to go all the way. So when you have a kid, the kids, the first thing the doctor is checking is first of all the head, the fontanelles. They're checking if there is some hip dysplasia, open and closed legs, and they touch the testicle, the scrotum, to know if the scrotum is occupied by the testicle. If the testicle is absent, the testicle is need to be there no more than 1 year, because if past more than 1 year, that testicle is going to just suffer degeneration. All right, so let's keep going. Here we have the spermatic cord. If you see this detail in the abdominal wall, this is a channel here. All what is exactly the arrow is showing. It's a channel, it's like a tunnel, and inside the tunnel is passing the spermatic cord. What we have in the spermatic cord? In the spermatic cord, we have some covered by muscles. This is the cremastaria muscle. And inside we have what? We have arteries, veins, and nerves. And what we have here is the testicle. All right, so that is, we already know what is a spermatic cord and what is the inguinal canal. So here we show the inguinal canal. So please don't be confused with the inguinal ligament. Inguinal ligament is part of the wall of the inguinal canal, but the inguinal canal is a channel. This is a ligament that is going to connect the pubic bone with the anterior superior iliac spine on the iliac bone. So it's a ligament only. But here is what we have, the inguinal canal is passing inside the spermatic cord. The spermatic cord contains all the testicle, the vein, artery, and nerve. Okay, so let's keep going. And there is one structure that probably we need to remember is the gubernaculum. Gubernaculum. So gubernaculum is, if you see this blue here, this is the testicle here, the gubernaculum is a projection or is a serous membrane that is attached to the inferior pole of the testicle. That gubernaculum is the one who is going to guide the testicle through, can you see this tunnel here, through the inguinal canal, and is going to get into the scrotum. Okay, so here we have, again, this is the gubernaculum, just to show in more in this cartoon. We have, this is coming from the abdomen here. This is the testicle, and the inferior pole of the testicle, we have attachment. This is serous membrane that is called the gubernaculum, and the gubernaculum is going to pull down, is going to guide the testicles through the inguinal canal down to the scrotum. All right, so let's talk about more detail about the testicles. So those are two glandular structures. They call endocrine and exocrine. So endocrine and exocrine. Endocrine because they produce the testosterone, and exocrine because they produce some substance, like, for example, the we are going to see the seminal vesicle fluid and the prostatic fluid. All right, within the scrotum is where is going to be produced the sperm. And they are going to be suspended through the spermatic cord. What is the spermatic cord is this. The size is going to be 4-3 by 2. And we are going to see the layers. Here we have the scrotum. We have 7 layers of scrotum surrounding the testicle. We have here the epididymis, so epididymis, sorry. And this is the beginning of the epididymis. So this is actually the tail, the body, and the head of the epididymis. All right, so we have here, and one thing that we need to start reviewing about the structure. If you see here, this is the testicle, and the testicle has a very fibrous cover. It's similar as we have a boiled egg. It's going to be a little bit more gray, more darker, but all this thick area, can you see this white thick area? That is called the tunica albuginea. Tunica albuginea. Plus, this tunica albuginea is going to have a projection. Can you see the continuation of the wall here inside? So they are going to create divisions of the testicle. These divisions of the testicles are going to be called lobules. Lobules. These are lobules. 1 lobule, 2 lobules, 3 lobules, 3, 4. And we have 250 of these lobules, where inside of each cavity is like we have a house with 250 rooms. And the tunica albuginea are the dividers or the walls of the house. So inside of each lobule, we are going to have one important structure that is the seminiferous tubules. If you see here, I want just to have a detail here of the wall of the tunica albuginea projecting into the testicle. All right, so here what we have, if you see here, we have these lines represent in this cartoon the walls of the projection of the tunica albuginea. Inside here, in this kind of pink color, is what we have. This is a lobule. What is inside the lobule are the seminiferous tubules. Seminiferous tubules. Inside the seminiferous tubule, let's pick up one seminiferous tubule out, and let's make a transverse cut of the seminiferous tubules. And what we are going to see is this. So here on the peripheral area of the lining of the seminiferous tubules, we have the spermatogonias. And the spermatogonias are actually cells that are creating more, they're going to create and mature spermatozoids. The second line is going to be a more mature cells, the third line and the fourth line, until they getting mature close to the lumen. Lumen is the space that we have in the seminiferous tubules. And here is where they are going to obtain the tail here. They obtain just then obtain the tail, and then we are going to see what happened. If you see here, the first line, that is the spermatogonium, they are going to have some what we call primary spermatocyte, secondary spermatocyte through the mitosis and meiosis. And what is important for this lecture is just to remember that from the inner portion, they are going to come towards the lumen, and they are going to get mature the sperm. Okay, the sperm, when they reach this level, is not technically mature yet. It's not ready for fertilization. And that process of maturation, of final maturation of the spermatozoid, is going to happen in another portion that is called the epididymis. We are going to see that in a few moments. All right, so here we have, again, this is a histological cut of the seminiferous tubules. This is a lobule, and here we have seminiferous tubules, and in the lumen we are going to see some fluid. Some fluid is not just an empty space. We have the spermatozoid here, and this mostly is going to be filled up with fluid and testosterone. We are going to see that in a few moments. All right. So here we have another close-up. Here we have this is one seminiferous tubules, another one, and another one, and another one, and you see here all this surrounding. But pay your attention what is in between. So what is filling up the spaces between the seminiferous tubules? This pale color is fluid, but some cells here are going to be actually what we call the Sertoli cells. Sertoli cells, you see here in this, we have, first of all, let's make it here, so inside the seminiferous tubule, we have the Sertoli cells that we just mentioned. And outside of in between the seminiferous tubules, we have the interstitial cells, or Leydig cells is the other name. The Leydig cells or interstitial cells. And this is the guy who is going to produce testosterone. And this is the this is the cell, sorry, who is going to nourish and protect the spermatozoid inside the seminiferous tubule. All right, so we was talking about the tunica albuginea, that is the cover that we just mentioned here. This is the cover. Then we have the seminiferous tubules, and we have about we have 1 to 4 seminiferous tubules. It's like a small spaghetti inside the lobule. But if we put together seminiferous tubules of one testicle, one after another, you're going to have about almost 1 kilometer distance. So if you put the seminiferous tubules one after another in a line, as a line, they're going to reach about 2 kilometers. It's a little bit more than 1 mile. All right. So we have, after this, if you see here, this is the lobule. Inside we have seminiferous tubules, and this is a small duct here that is going to is going to be for the transportation, the pathway of the sperm. These are going to be called, those are look like straight lines, right? So those are called the straight tubules. Then after the straight tubules, this small portion that I mentioned in the arrow, so they are going to drain in what we call the rete testis. Rete testis in Latin means a ret or net, like a fish net. So that is having the appearance of a fish net. So after the seminiferous tubules, the spermatozoids go to the straight tubules, and then they go to the rete testis. And then this, up to the rete testis is the testicle. Why? Because what is continued here, outside, is going to be the efferent tubule. Efferent tubule. This efferent tubule is already not considered part of the testicle. So the testicle is going to end at the level of the rete testis. Okay, so after the efferent, so we have seminiferous tubules, straight tubules, rete testis, and the efferent duct. They're going to go into a coil structure that is the epididymis. That is the epididymis. So after all this pathway enters into the epididymis. All right, so here again we have, if you see here, please, you have the lobules. Here inside we have seminiferous tubules. Here we have the straight tubules, and then they get into the rete testis. The rete testis then go out of the testicles through the efferent ducts or ductless, and then they're going to go into the epididymis. So this is only the part of the head of the sorry, it's the first portion of the epididymis. So it's a coronal view. All right, so that is about our pathway so far. So again, seminiferous, straight, rete testis, efferent, and then we have the epididymis. All right, so let's talk about the first cells that we have inside the seminiferous tubules, and that is what we call the nursing cells. Nursing cells, or called the sustentacular cells. So let me see if I can write it down, the sustentacular, just a moment. Okay, okay, just a moment, please. Okay, the Sertoli cells are going to be called the sustentacular or sustentacular cells. Sustentacular. This is A for me. Sustentacular cells. So that is the other name of the Sertoli cells. So what they are going to be called are the nurse cells, the nursing cells. So these nurse cells are the ones who take care of the, they're going to take care of the spermatozoids. So it's activated by the FSH. So this is the first thing that we need to remember for this lecture. FSH. The FSH is the follicular stimulant hormone that is actually, most of the people know that is mostly female, but in male, they are going to actually, the Sertoli cell have receptors for FSH. And what they are going to do, there is many, many functions of the Sertoli cells. Number one, mechanical and nutritional support. They are going to produce phagocytosis for all the cytoplasm that is discarded by the spermatides, blood-testis barrier, and they are going to secrete the actually anti-Mullerian hormone that is secreted about 7 weeks of gestation. That is going to produce the degeneration of the female reproductive portion, and is going to develop the male reproductive portion. So this is a Sertoli cell. The Sertoli cell, here we have all this is the cell. Here is the nucleus of the Sertoli cell. And here we have the spermatozoids that are going to get nourished from the Sertoli cells. We have another hormones that we are going to see just mentioned for this moment is the inhibin and activin. So they are going to, that is the hormones that are going to inhibit or activate according to the age of there's a moment where all these cells are going to, let's put it this way, wake up, and they are going to start to produce more testosterone, and that is what we start the puberty. Puberty starts about 11 12 weeks average in United States. Okay, so here we have the Leydig cells, and the Leydig cells are going to be called the interstitial cells or Leydig cells. So this is the one who is going to produce testosterone. Okay, so FSH increase the response of Leydig cells to LH, but the main hormone that is going to lead into the production of testosterone is the LH. So just remember, Leydig cells, L, is going to be stimulated by the LH. So L and L. And what is going to do? Testosterone. Meantime, we was talking about the Sertoli cells. Sertoli cells is going to be stimulated by the FSH. And what is doing the FSH on the Sertoli cells is going to promote the spermatogenesis. So we have two cells only, the Sertoli and the Leydig cells. Sertoli inside the seminiferous tubules are going to be stimulated by the FSH, and that is going to promote the spermatogenesis. Meantime, outside the seminiferous tubules, we have the Leydig cells that are going to stimulate by LH and produce testosterone. Okay, so talking about testosterone, just a moment. Somebody is actually, the audio is telling me something. Okay. All right. Testosterone. Testosterone is what we call androgen. Is a male sexual hormone, and this is being produced by the Leydig cells, as we already mentioned. And some part is going to be not only the testicle are producing testosterone, but the adrenal gland. So what is the difference? All right, so I will go very brief on this. Males produce testosterone and estrogens. Male produce testosterone and estrogens. These hormones coming from the testicle and from the adrenal gland. So what is the difference? The difference is that about 95 to 97% of the testosterone is coming from the testicles in male, right? Well, redundant, right? It's going to be coming from the testicle 95 to 97%. And the rest is going to come from the adrenal gland. Now, we produce estrogens, and the one who produces estrogens is the adrenal gland. So as a male, the proportions of estrogens and testosterone are different. We have a lot of testosterone, but a little bit of estrogens. In case of women, it's going to be the opposite. They have more estrogens, but a little bit of testosterone. Okay? All right. So this is, we are going to talk about, and the purpose of this class is to talk about the 5-alpha reductase. One thing we need to remember is why do we need cholesterol? Cholesterol we need for many reasons, especially three. Number one reason to take cholesterol is that cholesterol is needed for the cell membrane. If you put your hand under the table and you find a gum, that is actually the consistency of cholesterol in the cells, in the body. So that is giving you a structure to the cell membrane of the cell. This is number one. Number two is that cholesterol can are going to produce vitamin D, the vitamin D. And the third, actually, cholesterol is needed to produce sexual hormones. Cholesterol is needed to produce progesterone. We need cholesterol to produce estrogen. We need cholesterol to produce testosterone. So testosterone is the main fuel in order to produce these sex hormones. And we are going to remark the 5-alpha reductase. So we have here this hydroepiandrosterone, the DHEA. They have the testosterone, and we have the hydrotestosterone. So they have 1, 2, 3 types of androgens. So all together are going to be called androgens. So I'm telling you already ahead of time that we have the majority of the stronger testosterone or androgen we have in the body is that the hydrotestosterone, and we are going to see some implications here. So that DHT. Okay, as we already said, cholesterol levels need to be above 150. The normal values of cholesterol in blood, it should be less than 200. So more than 200 milligrams per deciliter, that means that you have hypercholesterolemia. You don't want that. But you need a minimum amount of cholesterol to produce in effective way the sex hormones. That should be above 150 milligrams per deciliter. Okay, so that is about this part. We are going to see the chart that I prepared for this class, and that is, if you see here, we have testosterone, we have androstenedione, the dexocortisol, corticosterone, corticoids, and this is happening, all this picture is happening in the adrenal gland, So you have, well, we are not going to talk about adrenal gland, but in the testicle, what is going to happen is just this second half, only this, what I'm marking here on my arrow here. So in the adrenal gland, all these are going to be produced. It's going to happen in the adrenal gland. But in the testicle, it's going to happen only this portion. Why? Because the testicle do not have these two enzymes, the 21 beta hydroxylase and the 11 beta hydroxylase. So that's why the testicle do not produce this this the aldosterone and cortisol. So what they are going to produce here, we have the pregnenolona that you see that is a precursor of the DHEA, the dehydroepiandrosterone, and they are going to turn into testosterone and then in the DHT. And the enzyme that is going to use to produce the strongest androgen DHT is the 5-alpha reductase. So we have that 90% of the androgens that we have in the body are going to be in the as testosterone, and 10% is going to be the dehydrotestosterone. What is important to remark here is that even though the 10% is the lowest, DHT is the strongest and the strongest androgen we have in the body. Testosterone is the weakest, is one of the weakest, but is actually what we have in more amount. The one who has in high quantity is the DHT. And DHT has some implications. For example, at a certain age, they start to have enlargement of the prostate that occur after 50 years old, and that is one of the reasons. So there's medications who are going to block the DHT. All right, so let's keep going. So serum DHT, that is the strongest, only 10% compared to the testosterone, but at least is twice as potent than the previous one, the DHT ED, that is going to be actually the strongest androgen that we have in body. Okay, so what is DHT doing? So let's go back here. This is testosterone, and this is the DHT, the hydrotestosterone, and this is the effect of this is to the scrotal pigmentation, enlarge of the penis at puberty, development of pubic and axillary hair, beard growth, and male pattern baldness. Okay, hoarseness of voice, increase in sebum, libido, aggression, muscular mass, and growth. One thing I want to tell you is that the DHT, the testosterone, are going to work together with a growth hormone. So the growth hormone is actually working in synergism with the testosterone and DHT. Okay, so one of the side effects, or well, something that we need to consider is that DHT are going to start making growth of the prostatic gland. All right, so here we have the control of testosterone, how it's going to happen. So we have here the hypothalamus that is going to release the gonadotropin releasing hormone. They are going to get into the anterior pituitary gland, and the anterior pituitary gland, they have the FSH and the LH. The FSH, what is going to do is to stimulate the Leydig cells, sorry, the Sertoli cells that produce the gametogenesis or spermatogenesis. Then we have the LH, and the LH stimulate the Leydig cells to produce testosterone. So if you see here, FSH, the Sertoli cells, LH, the Leydig cells, FSH, Sertoli cells, spermatogenesis, LH, the Leydig cells produce testosterone. When these are going to be effective on the spermatogenesis and the testosterone, they are going to trigger out some negative feedback. Negative feedback in the Sertoli cells, they are going to release the inhibin that is going to have a negative feedback in the anterior pituitary gland. Meantime, the levels of testosterone, so that is controlling the amount of the rate of production of spermatozoids. Here we have the testosterone that is going to produce a negative feedback. High levels of testosterone decrease is going to be negative feedback for LH, and for the next level, that is the gonadotropin releasing hormone. So that we don't want, that is what we call homeostasis, right? So we don't want too much or too little. So everything is going to be in the range. Okay, drugs alpha alpha reductase inhibitors. For example, we have the finasteride or propecia. We have another that is natural. That is what happens if we decrease the 5-alpha reductase. That is especially for uh, adult patients who are having enlargement of the prostate gland, and what they are doing is to decrease the DHT. How? Inhibiting or producing inhibition of the 5-alpha reductase. If we go back here, so this 5-alpha reductase is going to be inhibited. And we are going to decrease the levels DHT. And you remember DHT is the strongest, the more potent androgens. And that is going to be treated for treatment to decrease the or slow down the increase of the size of the prostate. So we have here, for example, some natural part can be part of OTC, over the counter. So palmetto, the L-lysine, and we have another, the green tea. So I forgot to put here the green tea. So all of these are promote the decrease of the activity of the 5-alpha reductase, 5-alpha reductase, and they are going to inhibit this enzyme. We have, this is the name for treating urinary problems. You know, the prostate is going to be enlarged, can produce constriction of the urethra. We have, in addition to that, we have the doxazosin, that is an alpha-1 blocker. So alpha-1 itself produces vasoconstriction, but this alpha-1 blocker produces the opposite, the vasodilation. In addition to that, they're going to decrease because the prostate has a muscle. In the upper portion of the prostate, we have muscle, and what is doing this alpha-1 blocker is to relax that muscle. So to prevent the hypertrophy or hyperplasia, whatever you want to call, it's not the same, but depends what terms you are talking. They are going to decrease or slow down the process of enlargement of the prostate. So here, just to show you here the supporting cell of Sertoli cells. So they are going to be the how they are going to develop. They are going to develop until they are going to get into a mature spermatozoa. The transportation of the sperm of the testis to epididymis to the urethra. So how is the pathway? The pathway will be seminiferous tubules. They go to the straight tubules. They go to the rete testis. They go to the efferent ductals, and they are going to go to the epididymis. This is the head of the epididymis, the body, and the tail of the epididymis. So what is the function of epididymis? There are many functions, but the main thing of this epididymis is the spermatozoids are going to get into the epididymis in immature form. So they are not ready to fertilize. It's getting here in the epididymis where they are going to start reaching the maturity enough that during the ejaculation they are going to come out from the epididymis, and then they are going to be replaced by the cells that are immature for more time to make them with the time get mature. All right, so let's see, the efferent ductals, we have the efferent are going to come out. These are the efferent ductals, and they are going to connect. It's a continuation through the epididymis. So epididymis is not like a big, let's put it, container. It's a very intricate, convoluted ductals that are going to come and form one structure called the epididymis. So this is epididymis. So this is anterior, this is posterior. So here we have all what is here is going to come if you see here, this is the head, the body, the tail, and they are going to start the vas deferens. The vas deferens. The vas deferens is going to measure about 4 millimeters diameter, and they are going to measure about 1 foot. So that is where it's coming from. So this is the epididymis, then we go all the way up. This is the vas deferens, and the vas deferens is going to come together with the arteries, veins, that is part of the spermatic cord. So this is the histological cut of the. This is the seminiferous tubules. This is the straight tubules, and here we are going to see the efferent ductworks. So they have a different, so just to demonstrate the transition between the seminiferous tubules towards the epididymis layer. The function of the epididymis is, first of all, the sperm is moving along the tube for maturation and storage until ejaculation. So that is the main function of the epididymis. As you can tell, during the ejaculation, there is a smooth muscle on the ducts. There is a smooth muscle on the ductus. So they are going to all contract and they are going to eject. That's how the sperm are going to be ejected to the next level. All right, so that is where in the epididymis is going to gain maturity and the motility of the sperm. The vas deferens are going to carry the spermatozoa from the epididymis to the ejaculatory duct, and this is something that is sometimes confusing about the ejaculatory duct, and this is something we already mentioned. Muscular contraction in the vas deferens is facilitated by the oxytocin and the prostaglandins. Oxytocin, we know that is secreted by the posterior pituitary gland, and the function is contraction of the uterus in female and the ejection of the milk. But in male, we have a function too. This oxytocin is going to contract the smooth muscle of the vas deferens and other muscles, and this vas deferens is going to create like some kind of propulsion to the sperm going towards the urethra. Okay, so here we have, if you see here, we have the testicle, we have the epididymis, we have the vas deferens. Vas deferens all the way up, they are going to come inside the body through the spermatic cord. So the spermatic cord is going to have vas deferens, arteries, veins, nerves, lymphatics, and they are going to come inside the body and all the way up. Look at this, they're going even posterior to the urinary bladder. So here there are two structures. If you see here in detail, this pathway is the vas deferens that is going to drain here. But in this point, there is another duct that are going to come simultaneously too. That is the seminal vesicle. Seminal vesicle, 60% of the semen is going to have some substance that produce energy to the spermatozoa in his pathway, especially fructose, and there 60% of the volume are going to come here. So this is seminal vesicle fluid plus the sperm coming together, and that is what we are going to see now. If you see here, we have here the urinary bladder. We have this this structure is the prostate. This is the prostate. Here we have the urethra. When it's passing through the prostate, it's called the prostatic urethra. Prostatic urethra. So when there is ejaculation, there is no way that is going to come urine with the semen. There is some valves here that during the contraction are going to close, that is going to close the doors for the urinary bladder. So it's not going to be mix of urine and sperm. So this is the prostatic urethra. This is the seminal vesicle gland. Here in this side is coming the vas deferens. This is the seminal vesicle duct coming from the seminal vesicle gland. And here's the vas deferens forming and this portion is called the ejaculatory duct. This is the portion we call the ejaculatory duct. So ejaculatory duct is going to join the prostatic urethra and then go to the urethra. So here we have some cartoons. We have that this is the tunica albuginea. Then we have the seminiferous tubules inside. Then we have this is the rete testis. Before that, we have the straight ductals. Then after rete testis, they go to the efferent ducts. The efferent ducts that are going to join, they are going to go into the epididymis, and that is the pathway that they are going to be in the body. Neck, body, head, body and the tail of the epididymis. And this is the vas deferens. Okay, so let's keep going. So this is the vas deferens, or ductus deferens is the same. So you can see here that the vas deferens is about 4 millimeters, but the pathway or the lumen, I mean, is about 1 to 1.5 millimeters. It's very tiny, but it's enough space for the sperm to go through. So you can tell this in comparison, the proportion of the smooth muscle are very remarkable here. And that is how you can explain the oxytocin prostaglandins are going to make the contraction and the ejection of the sperms during the ejaculation. We are going to talk about the pumpidiform plexus, because if we remember, we was talking about the spermatic cord, the spermatic cord that goes through the inguinal canal. The spermatic cord is going to have veins. These veins, because of the distribution that they have, is called the pumpidiform plexus. We have another pumpidiform plexus in female we are going to see in the next class. But if you see here we have the testicle, epididymis, vas deferens, and the vas deferens is this red is the artery, the spermatic artery coming from the aorta, and this is the spermatic vein. Well, I'm not going to talk about how they're going into the body, but these together are going to form a spermatic cord. A spermatic cord is including this muscle. Those are extensions or projections of the muscle that are going to surround the spermatic cord. A spermatic cord is this, all this, and it's going to go through the inguinal canal. You can see the opening there. Oops. Okay, so I think we finished the lecture for male reproductive system. If there is some questions, please let me know. Hello?
Oh, that was very good. Thank you.
Okay, Joe, thank you so much. Have a very good night. And you, Sarah, how are you?
Thank you. Good night, too.
Good night. Thank you.
Bye, Sarah.
Good night, Joe.
Sarah, are you everything fine? Any question? No?
I think I'm okay, Dr. G.
Okay,
It's
perfect.
It was pretty good.
Okay, muchas gracias. Thank you so much. I will see you next time. And please, Joe and Sarah, I will send the file and I will send you the link for that. Thank you so much. Have a good night, all of you.